I have given you a copy of these slides, thanks to Debbie. She's provided them. And, whenever we speak about diabetes to a group of people, we know that there are some people in the group who know a lot about diabetes and know a lot about the medicines. In fact, some of you may know as much or more about the medicines as I do because you may have been living with diabetes for many, many years. And so then we also understand that there's some of you in the audience who perhaps have just recently been diagnosed with diabetes or have a family member who's just been diagnosed. And so you may be at the very beginning point of that curve. So as Debbie alluded to earlier, my slides may seem a little bit complicated. There's a lot of information, but for some of you who know a lot about the condition, they may be just right. For others, they may be too much. Regardless, the main thing we want to do tonight is make sure your questions about diabetes medicines are answered. Now, the other thing I want to tell you is that diabetes medicines are not just as simple as the medicines that are used to lower your blood sugar. It's a little bit more complicated than that. There are medications for high blood pressure that oftentimes goes along with diabetes. There are cholesterol medications which are often used together. There are sometimes other medications that go along, but tonight we're just going to focus on the medicines that we use to lower blood sugar. That's what we're going to spend the entire time on, are just those medicines. And I'm going to talk about some that you've heard of a lot and some of them that are brand new and new drugs that you might have heard of or might have even seen advertisements on TV. So let's get started with this. And maybe I'm not clicking. Okay, I got something to go. There we go. First of all, let's start with insulin. Now, most people, when they think about having diabetes or living with diabetes and treating diabetes, insulin is oftentimes not the thing that you often want to think about first. But I'm going to give you some basics of understanding of how insulin works. Now, this graph that you see here basically shows what's going on in your bloodstream related to insulin. So that blue line that takes these tall peaks and then comes down into these valleys and has these little lines going along, that's what insulin normally does in your body throughout the day, starting with a meal at breakfast and going all the way through the whole day and then on through the night. And so you'll see that after you eat, your body's natural response to the presence of carbohydrates and a food source is to excrete insulin. And what insulin does is insulin helps your body use that energy source. Every cell in your body needs energy to survive. Your muscles, your heart, all of your internal organs, your brain, your eyes, everything needs energy that's provided by food. And in order for that energy to get where it needs to be, you need insulin. You need insulin to help make that happen. And so what occurs in the case of diabetes is that there's two or three things that can happen. In type 1 diabetes, as you're probably aware, your pancreas, the part of your body that makes insulin, that pump quits working. It quits doing what it's supposed to do and stops producing the insulin that you need. And what that means is that your body then does not have the ability to process those carbohydrates and use that energy the way it's supposed to. And so what happens is your blood sugar runs very, very high as a result of no insulin. The second thing that can happen is that maybe your insulin pump, your pancreas, is working like it's supposed to in these nice, pretty rhythms like we see here on the slide, but because of lots of reasons, it could be obesity or it could be just changes in our metabolism, insulin is not able to open the door of our cells so that the energy can get inside. So just imagine this. Your cells are a little door. They have a keyhole. That keyhole has to be opened so that the energy can get inside where it's supposed to go. Over time, what happens with some people is that keyhole changes shape, but the key is still the same. And if the keyhole changes and the key is still the same, then that door is not going to open. And that means you're not going to effectively use sugar the way that you're supposed to. So we have some drugs in our armamentarium to treat diabetes that help get that keyhole to where the door will open. Okay? So we have some medicines that help with insulin, and then we have some medicines that help our body use insulin the way that it's supposed to be. And so essentially, all the drugs we're going to talk about tonight are really dealing with those two things. Now, there are a couple of drugs we'll talk about that deal with how your body absorbs sugar in the stomach and so forth, but we'll primarily focus on those two things. So that's how this works, how your body uses insulin. Now, a lot of you who have been familiar with insulin, if you see regular human insulin, you'll see it from the pharmacy, Humulin R or Novolin R. You'll see those products. Anybody familiar with that? This is yes and this is no. Okay, great. Okay, so those products are very commonly used to treat diabetes. And human insulin comes in different concentrations. And this is important for you to know, because if you are utilizing insulin to help with your blood sugar, one of the things that you should do to protect yourself and to ensure safety is always look at the vial when you get it from the pharmacy and make sure your insulin is the right strength, because the packages all look the same. The only thing that's different is the strength. And the pharmacy will do a good job trying to make sure you get the right drug, but you should always make sure for yourself that you have the right thing. So U100 means that there are 100 units of insulin in each milliliter of the insulin. U200 means 200 units, U300 means 300 units, and so forth. U500 is the most concentrated form of insulin that we have. 500 units of insulin in 1 milliliter, very concentrated insulin. The vast majority of people who are using regular human insulin will be using U100 insulin. So take a look, if you're on insulin, take a look at your vial and see what your vial says. If you're on regular human insulin, it'll say U100, 200, or 300, or 500. And you want to just take a look at that and always check your vial before you open it and give yourself a shot. Whoops, I went the wrong direction. So how many different types of insulins are there? Well, this says bolus dosing. What this means is that some insulins are relatively short-acting insulins. They provide the effect that they're supposed to provide. They do it immediately, fairly immediately. Within 15 minutes, you get a response from that insulin, and they don't last very long. They're intended to take care of what you're eating right now. Think of it like that. Short-acting insulins are intended to take care of the sugar that you're consuming, and not just sugar, the carbohydrates. That's really the better word to use. The carbohydrates that you're intaking right now are taken care of by short-acting insulins. So regular insulin, Novolin R, Humulin R, and Afrezza, and we'll talk about Afrezza in just a minute. It's an inhaled insulin product instead of by injection. And then there's Aspart glulisine, so Novolog or Apidra, and then there's one called Lispro insulin or Humalog, and Humalog comes in 2 concentrations. And oftentimes these bottom 3 are given right before a meal, and sometimes, depending upon how well controlled your body sugar is, they may be given via an insulin pump, or they may be given before every meal. So you might actually have very short-acting insulins being given several times a day or via an insulin pump. Okay? Normally, regular insulin is given at morning and in the evening, normally when it's given, or it's given via an insulin pump. So a little bit different dosing, but these are short-acting insulins, very different insulins. Now, Regular insulin, just to give you a little bit of an insight here, regular insulin is modeled after human insulin. It's identical to the structure of human insulin. These other three are biotechnology advancements. They're faster acting insulins than regular insulin even, and these are the ones that we oftentimes see more commonly today. They're beginning to become more popular than regular insulin because they allow for us to have more immediate control based upon the meal that you're about to eat. And this is one of the reasons why you really need to be present for that discussion that you're going to have on carbohydrates and dietary and mealtime, because these two things go very much hand in hand. If you don't understand carbohydrates and how your body uses food, then your medicines will make no sense whatsoever, because the medicines are totally dependent on that. So really important that you come to that discussion. So of these regular insulins, you see lots of abbreviations on this because I pulled it from a pharmacy student presentation. But Humulin insulin and Novolin insulin, regular human insulins, do not require prescription from your doctor, believe it or not. They're over-the-counter. They're considered over-the-counter insulin. So if you were to be in a situation where you run out of your regular insulin and it's 5:30 p.m. on Friday evening, it's a little late to get a hold of the doctor's office for a refill, isn't it? Well, because insulin is considered a life-sustaining product, without it we can't live. We have to have insulin to live. So if a person needs regular insulin, the product was made over the counter regular because no one is going to use that product unless they really need it. And so that's why it's considered an over the counter product. You just need to go to the pharmacy and ask for it, and you can get it even if your prescription is run out. I say that, and I'll tell you, you always want to have your diabetes managed by someone who's qualified to help you manage it. Now, Alfreza, you may have heard of, is a inhaled insulin. And this is an interesting advancement because one of the objections many people have to using insulin is they don't want to give themselves shots. And they're afraid of the needles. And I'll tell you that, first of all, the advancement in insulin dosing technology is so advanced now. It used to be that you had to draw up the doses out of vials and mix them together, and some people still do that, but you don't have to do that anymore. We now have pens, insulin pens, that have teensy tiny little needles. I mean, they are so small that honestly most people don't even know that they've stuck themselves with a needle because you can't hardly feel it. They're such tiny needles. The insulin just needs to get right underneath the skin. It doesn't have to get very deep. It just has to get right underneath the skin. So these teeny tiny little needles now allow us to give an accurate dose of insulin. And so it's so easy to use insulin these days compared to the way it used to be many, many years ago. And as a result of that, many people now are using insulin earlier. Now, this isn't on the slides, but I'm going to throw it in. It won't cost you another dime, okay? Here's the thing. Don't be afraid of insulin. Your body has to have it. Your body does have to have insulin. And the complications of diabetes are very serious. And so many people put off trying insulin to treat their diabetes because they're afraid of the low blood sugar they might get if they get too much insulin. They're afraid of the injections, maybe afraid of different things. But let me tell you, if you're working very closely with a certified diabetes educator and you're working very closely with your healthcare practitioner, whether it's a physician, a nurse practitioner, a physician's assistant, or a pharmacist, you're working very closely with them to keep your blood sugars regulated, there's no reason to be afraid of insulin, because if you are utilizing insulin, it helps your body maintain normal function for a longer period of time. If you wait until you've maxed out all the doses of all the oral medications that you could possibly take and your blood sugar still won't come down, then we've got a lot of catching up to do. And by that point, you may already have developed complications. So you can put off the complications oftentimes by going to insulin sooner. That's something worth talking to your doctor about if you've never had that complication, that conversation, especially if you've had diabetes for a long time and you've had difficulty managing it. Now, Lispro insulin, Aspart insulin, and glulisine insulin, and you can see the brand names there, they usually need to be given within 15 minutes of taking your first bite of food at a meal. Because if not, you're going to have a low blood sugar, because they act very quickly. They act very, very quickly. So you have to be right on it if you're ready to take a meal. And normally that's what people do. If they have these, they have a little pen. In fact, a lot of people who have diabetes will have their insulin pen and they'll put it in their pocket. It's got a little clip on it just like an ink pen, and you carry it around with you all day. Gentlemen, ladies, you can stick it in your purse. It fits very easily. And then you see what you're having. Oh, I don't know what we're having for lunch. And you get there and say, oh, we're having hamburgers. And for the sake of our dietitian, we're having vegetables, okay? Hamburgers and vegetables, okay? Well, you can figure out, you'll learn how to count carbs. You'll learn how to click up the right amount of insulin before you eat that meal. Give yourself that injection and then go at it and have all that food that you want to have at that particular meal. So this is the way it goes. The pens are not over the counter, so the pens that we use require prescription. They all require prescription. So very important, and that's a great question. Now let me move on here. This is a little picture that just shows here that if you are using injectable insulin, and the only point I put this picture in here for is if you're using injectable insulin and you are thinking about switching, or your doctor's thinking about switching you to inhaled insulin, there is a conversion factor that you have to take into account. 1 unit of injectable insulin is not equal to 1 unit of inhaled insulin. There's a difference in the way these two drugs work, because our lungs have a great blood supply, and the amount of insulin that's absorbed quickly through your lungs is pretty good. It's good absorption. So just know this, you don't need to know anything from this chart. It's just to remember that if you decide that you want to use an inhaled insulin instead of an injectable insulin, then you will know that the dose is going to look different. Don't think that your healthcare provider messed up when they gave you the dose. It's going to look different than your current insulin dose if you're on insulin. There are also some longer formulations of insulin, and I've started at the top with the shortest of the long-acting insulins, and we've ended at the bottom here with a product called Tresiba, which has the longest action. And these are often referred to as basal insulins. Basal simply means baseline. It means baseline. A constant amount of insulin that's present in your body to respond to your normal physiologic or body's needs, your normal body needs. A baseline level of insulin. And a baseline level of insulin makes sense, doesn't it? Because remember those normal peaks and valleys our body has throughout the day? Some of those peaks are in response to what we eat, but our blood sugar goes up and down a little bit here and there all throughout the day as we metabolize, as our bodies metabolize, and based upon the amount of exercise we get, our bodies change the amount of insulin. So that previous kinds of insulin I talked about were what we do in response to the food we eat. What this is what we need to be able to truck along at an even path no matter what we eat. So a baseline level of insulin. And so that's what these kinds of insulins are all about. And you may have heard of these: Levemir or Lantus, Toujeo or Tresiba. And then there's Basaglar. Those are all the brand names of these insulins. Occasionally concentrated insulin is used in the same way, the U500. But the way this works is when you give the injection, if you could look at it under a microscope, this kind of insulin, you would see that the molecules of insulin are in little clumps. You see how that is here on the slide? They're in these little clumps. And what happens is those little clumps, as they enter into the tissue, over time, takes a while to do this, they begin to separate. And each one of those little components, as it separates off, then can enter into the bloodstream and can function as insulin the way it's supposed to. So what this really does is it's a slow release mechanism to slowly release insulin consistently over time. And that's great because that gives us a baseline insulin. And so people who are using these baseline insulins will typically use them once a day, oftentimes in the evening, and they will take the same dose day after day after day after day, and we usually don't change those doses very frequently. Those doses pretty much stay the same once we get regulated. Once your blood sugar is regulated, that dose doesn't change much at all. The other doses change based upon the amount of food we consume. We see changes in those, but these doses don't typically change. And this is just another picture to show that Levemir does the same thing. And it approximates your body's acidity, so it's about the same as your body in terms of the way these molecules work and release into your bloodstream. So all of these work in that same fashion. And this is just another picture showing the same thing. Your body's such a complicated thing. You know, I don't know how anyone could say that there's not a God. Because if you look at the human body and the complexity of the way the human body works, it's amazing. There's no way that was an accident, folks. It was a holy God who made our bodies. And so it's great that we have medicines to be able to take care of us here in this complex body that we have. Again, the humulin N and novolin N, NPH, those are the of these long-acting insulins. This is the shortest of the long-acting insulins, but that NPH insulin is over the counter. It is, again, oftentimes used twice a day. Now, what you may see is that, or if you've been on insulin for a long period of time, you may be on Humulin 70/30. Anybody on Humulin or Novolin 70/30? Okay, a couple of people. What that product contains is a portion of this NPH and a portion of regular insulin mixed together in a ratio of 70/30. 70% one, 30% the other. And then you get regulated on that, and it's one dose in the morning, one dose in the evening, and that's how you manage your insulin. So that's how the NPH insulin works. Lantus, Levemir, and Tresiba, as you can see here, are longer acting insulins. These insulins cannot be mixed with regular human insulin. So human insulin, Humulin R, or Novolin R, those products, we cannot mix with these products. So we don't mix them in the same syringe. Whereas with Humulin R and NPH insulin, we may, in fact, sometimes mix those in the same syringe. Okay? So very important, don't just mix insulins together. I'll talk to you a little bit about mixing insulins, but don't mix insulins together unless you've specifically been instructed to do that by your healthcare provider, because that could lead to some deadly results. Now, I've mentioned here that there are some formulations of mixed insulin where you have a long-acting insulin and a short-acting insulin mixed together in the same product. Some of the manufacturers produce those for us just to make it a little easier on folks so that they don't have to give as many injections, so you don't have to have as many injections. So that's a good thing. There's a lot of those products, and I'm not going to go over them in detail, but just understand that your healthcare provider, who's an expert in diabetes, will do their very best to find the best insulin combination for you so that you get the best control of your blood sugar. The bottom line is this: is there one product that's better than another? No, it all is up to you. It just depends on you. Everybody's an individual. God made us uniquely, not just complicated. Okay, so we're made uniquely, and so we need to find the right product, the right drug product for you to meet your physiologic needs. That's important. If you are mixing insulins, you always draw up the regular or rapid acting insulin first, and it's always clear. And then you draw up the long acting insulin second, and the long acting one is always cloudy. So you draw the clear one into the syringe, then you put the cloudy one in the syringe. And the idea tonight is not to make you an expert about insulin. Again, if you begin using insulin for the first time, be sure to ask your healthcare provider for some special training in how to utilize insulins safely. Now, where do you give an insulin injection? This is the question this is the part that makes people a little afraid sometimes. Where do I give myself the injection? Well, normally insulin is administered in the tummy, in the abdomen. Now, why do we do that? Well, number one, it's easy to get to your belly, okay? It's easy to get there. Number two, there's a physiologic reason. Insulin is absorbed really easily in that part of your body. So it means that the insulin's going to work most effectively if it's administered where it's absorbed into your body the best. And so when you give the injections in your abdomen, then that's the easiest thing to do. I'll also tell you these teensy-tiny needles I told about earlier that are with these pins, if you have appropriate technique, if you're doing it the right way, it's relatively it's not painless, but it's relatively painless, and it's very quick. It's a very simple and quick process. Now, if that's not a possibility, you can give the injection in your arm. Some people do it in their forearm. You can give the injection in your hip. That's a little bit difficult to do for most of us, okay? But you can do that. You can give the injection in your thigh if you would prefer to do that. And you can give it straight in your rear end, okay? But the abdomen is the best place to give the injection, and you want to rotate the site where you give it. Now, why do you want to do that? Well, I'm going to show you. Where's my picture? I had a picture. Is my picture in here? Oh, I got to get to my picture, and I'll come back to this. Okay, this is my picture. I didn't get it in the right spot. This picture shows here someone who has been giving insulin injections, and they've got a lot of bruising on their belly and on their thighs. And I think this next one shows something also. This is where the fat tissue in that area has indented. There's been a loss of fat tissue there. How do you prevent these two things from happening? How do you keep from having the abnormalities in the fat tissue no matter where you give the insulin injection? And how do you not have the bruising? Well, very simple. You rotate the site of injection. If you're giving yourselves injections of insulin, you should not be giving it in the same place every time you give an injection. You should be rotating, and oftentimes what your healthcare provider will do is they'll provide you with a little diagram of your belly that looks like a grid, and you can mark on that grid where you gave your last dose in case you have trouble remembering, and then you just move across that grid to be able to administer the doses. So you can do that. But at any rate, this is how these work. And now I'm going to go backwards. And I'm good at that because I've already shown I can't push the thing the right way. All right, let's go backwards. Hypoglycemia, insulin. Okay, yep, right here we are. So, the biggest risk associated with insulin, biggest risk is low blood sugar. So, that's what it's supposed to do, right? The action of insulin is to lower your blood sugar. So, the risk of insulin is it could make your blood sugar go too low. And that's a scary thing. Has anybody had a low blood sugar before? Yeah, all of us have had a low blood sugar at some point in time. And when you have a low blood sugar, it can be pretty scary. You get sweaty, and you know all the symptoms of that, shaky, and sometimes it can get so low that we pass out. But we certainly don't want that to happen, but that is a risk of using insulin, which is one of the reasons why you just want to be trained and know what you're doing. But it's once you got it, you got it. You can do it. The second thing is weight gain. When our body is utilizing carbohydrates appropriately and your body's function, insulin goes back the way that it's supposed to, sometimes we can want to consume more food. Sometimes the insulin itself can cause us to gain weight. And so weight gain is commonly seen with insulin. But an appropriate exercise plan coupled with your diabetes medications will help with that. And then injection site reactions. Now, it is possible to be allergic to the insulin products. You stop and think about that. How can your body be allergic to something that it makes on a normal basis? Well, it's possible. It is possible to be allergic to some of these insulin formulations. And so if you ever do have a reaction, it's unusual, but if you ever do have a reaction following an insulin dose, you want to be sure to ask your healthcare provider about that.
What type of reactions are there?
So the different types of reactions that you can have with insulin, low blood sugar, or with the insulin, you mean in terms of the allergic reaction. So the allergic reaction would be to break out in a rash at the site where you give the injection. It could be, usually you're going to have a rash with potentially even something more severe than that, but it's going to be a pretty pronounced rash at the site where you get the injection. That's going to primarily be what it is. Okay, I'm going to go on to a couple of other things that I wanted to cover with the medicines. Metformin. I bet 80% of you have heard what a metformin is. Anybody know what that is? Metformin. All right, seeing a show of hands, it looks like most everybody's familiar with it. Metformin is the most frequently prescribed diabetes drug in the United States right now, today. Actually, it's the most frequently prescribed diabetes drug in the world today. Okay? So it is a very commonly used drug. Why is it so frequently prescribed? Well, it works. That's the bottom line is metformin works. It's called glucophage, that's the brand name, or Glumetza, but most people take generic metformin, and it works very well. It's where we normally start when someone is newly diagnosed with type 2 diabetes. We almost always start with metformin. And normally the starting dose of metformin is 500 milligrams, and then we slowly work our way up from there. The maximum amount of metformin that routinely is taken is 2,000 milligrams a day. Occasionally we'll see people who are taking 2,500 or 3,000 milligrams of metformin a day, but the literature tells us that you don't get a lot more beneficial effect from metformin over 2,000 milligrams. Now, I don't want to cause anybody to second guess the dose that you're on. Every individual is a little bit different, and you may have found doses, your physician may have found doses that work for you. But for the average person, they don't see much more benefit after 2,000 milligrams. The number one side effect that patients notice from having to take metformin is diarrhea or a loose stool. That is the most common abdominal discomfort, diarrhea, and a loose stool. Now, usually, if that diarrhea or loose stool is not too bad at the beginning, if you'll stick with it for a few weeks, 3 or 4 weeks, then it will go away. It's usually not severe diarrhea like you would experience with virus, for example, if you had a viral infection. But sometimes it can just be intolerable and you just have to get off of it and try something else. So that happens. The other thing for you to know is that you need to be sure that you have your blood work done on a regular basis. Your physician or nurse practitioner, physician's assistant or pharmacist that's managing your diabetes is going to want you to have blood work done if you're on metformin on a fairly regular basis. And you want to do that because what they're monitoring is your liver. Metformin is metabolized by your liver. It's broken down in your liver. And in order to get it broken down appropriately, we need to make sure your liver is functioning correctly. And sometimes after you're on metformin for a while, it can cause some injury to your liver. And if they begin to see that in your lab work, then they'll stop the metformin. So it's important to know that. Now, I'm going to pass this. I put this in here again, primarily for people who may be more, maybe have a little bit more advanced understanding. And what I'll just tell you is that if your kidney function, okay, is not good, if you've been told that you have severe kidney disease and you might be on dialysis, then your doctor may not, in fact, use metformin because of your kidney function, because your kidneys also have to be working in order for the medicine to work. Now, for those of you who've had diabetes for a number of years, you may remember this group of drugs. This is called the sulfonylureas, but you may remember glucotrol or diabeta. Anybody remember these drugs? No? Okay, a few of you do. Okay. Glipizide, glimepiride, Amaryl, or glyburide. There's also some even older ones, and we rarely see these used now, but it might be possible that you know about those, diabinase, tolinase, or orinase. But these drugs are still used. Glucotrol, diabeta, and Amaryl are still used, and these drugs help your body use insulin effectively. That's what these are for. They're to help your body use. They work a little bit differently than metformin. The difference between these drugs and metformin is that these drugs are a little more likely to cause you to have low blood sugar episodes. They're a little more likely to cause you to have hypoglycemia than metformin. Now, metformin can cause that too. In fact, any medicine for diabetes can cause your blood sugar to go too low. But these drugs are a little more likely to do that, and so you have to be aware of that. And these drugs also have to be taken for sure with regard to meals. You do need to take them at least, no more than 30 minutes before a meal, or else you're going to experience a low blood sugar reaction almost certainly. Once you take these medicines, they start working in about 30 minutes. Metformin has a controlled release formulation. It's not quite as critical that you eat immediately after you take metformin for most people. That releases a little more slowly over time. These drugs, on the other hand, you really need to watch out for that. Now, there are special things about some of these drugs. Again, some of these drugs cannot be taken if you have kidney disease, and some of them cannot be taken if you have liver disease. You always want to talk with your healthcare provider about that before you start. And also, if you're allergic to sulfa drugs, okay, sulfa drugs, these drugs are not an option for you, okay? Because you may be allergic to sulfa drugs because you took an antibiotic one time that was a sulfa drug and you broke out in a bad rash or had whelps or whatever. Well, if that ever happened, okay, then you can't take these drugs, because these drugs, your body looks at them like sulfa drugs. You'll have the same reaction as you had to that antibiotic, even though they're two different drugs for two different purposes. So, yes, these drugs that I'm talking about right now, these sulfonylurea drugs, can be taken together with metformin, but usually we don't start someone that way. So normally we'll start someone on just metformin, or usually just metformin, and then once we get to a certain point, if we're not getting the result we want, then we might add glipizide or glyburide or Amaryl to that in order to get a better effect. But so it's fine to take those together if they've been prescribed, and it's not unusual for those to be taken the same person. Now, I'll mention these drugs. The bottom drug that's listed here is actually not on the market anymore, but I put it up here because I thought some of you might have questions about it, Avandia. It's not on the market. And then Actose pioglitazone is. And these drugs have some problems with them, and they're not very popular. We don't see them used very often. And so I don't want to scare you away from it if you happen to be taking one of these drugs, but these drugs did, we learned after they were on the market for some period of time, cause some significant liver damage potential, and can increase the risk of bone fracture, especially in people who may already have underlying osteoporosis or brittle bone disease. So these drugs have kind of fallen out of favor. I wanted to throw them in here because you've heard of them perhaps in the past, but these are not something that you're likely to see used except in just a rare circumstance that you would use it. What's very new, or what is more new, I got all those very, very new, but these are newer drugs, and they have really long names. Let me just say this. These drugs work through two very unique mechanisms on two very specific processes in your body that produce on the utilization of insulin and the way your body uses carbohydrates, okay? So I'm not going to get into the details of exactly how they work because it's very complicated, but I will tell you that these drugs, one of them inhibits an enzyme called DPP4, and there's 4 different drugs on the market. They all act the same way. They're just made by 4 different companies, okay? One's called Januvia, Onglyza, Tradjenta, and Nesina. And they all have the same, the thing that's in common with all of them is they use this suffix Gliptin, gliptin. They all work the same way. And these drugs, again, have to watch out for potential low blood sugar reactions. It's the same with every one of the diabetes drugs. And the other thing I want to tell you, and this illustrates it probably better than any of the other drugs, so I wanted to point it out on this slide in particular. When you hear milligram dosing for oral medicines, you have to understand that a milligram of one drug is not equal to a milligram of another drug, okay? So a milligram is a weight, it's a measure of weight, but it doesn't tell us a lot about concentration when we compare one drug to another. So, for example, you'll notice here that saxagliptin or Onglyza, that the normal dose is 2.5 to 5 milligrams once a day. But you'll notice that sitagliptin or Januvia that's up above it has 100 milligrams per day. And you'll say, oh my goodness, I don't want to be on 100 milligrams. I only want to be on 2.5. Well, those are actually about equal doses. One of them is just weighed differently and measured differently than the other. So it doesn't mean that one's better than the other or that you're on a lower dose. You're actually on about the same dose of those two medications. It's just measured differently. And I know that's a little bit confusing, but I don't want you to think that, well, you know, I've got to be on 100 milligrams of this or 500, or somebody says, well, I don't know exactly what it is I'm on, but I'm on 1,000 milligrams of it. Well, don't worry about that because it may be very different than the drug you're taking, and the milligram concentration may not be equivalent. There may not be an equivalent dosing. So don't ever get worried. And some people get worried about the milligrams of their drugs, and I don't want to be on a bunch of milligrams. Don't worry about milligrams, because small milligrams or big milligrams, it only matters for that drug. It's calculated for that drug, and it's very unique for that particular drug. Now, the nice thing here is that these medications tend to not cause as much weight gain, so that's nice. Metformin sometimes does not cause as much weight gain, and partially because of the upset stomach, and so we can see a little bit of both in here. There are some lab testing that has to be done with these medicines too, so just remember to always, whenever your doctor tells you need to have some blood work done, I know it may get old and you may get tired of it, but it's really important when you're on these medicines so that they can make sure the medicines are doing what they're supposed to. And so I've put information in here for those of you who have been are more familiar with medicine. Sometimes I have nurses and doctors in this class, and I wanted to give you the renal dosing in case you have that background, but it's not that you can ignore that otherwise. Another group of drugs works just a little bit different, and it helps the sugar, the sugar get out of your blood and into your cells in a little different way. And this uses a very specific process. These drugs are even newer than that last group of drugs that I talked about. And these all end with the suffix Flozin, Flozin, Flozin. So they're a little bit different. You can tell that they're two different drugs by the way they're named. They've got just a slightly different name. Invokana, Farxiga, and Jardiance. And I don't know how they come up with these names. I got to tell you, I have no clue how they come up with these names. Some of them are creative and some of them are just hard to pronounce. That's just all the way there is to it, and I don't know how they do it. So anyway, somebody much smarter than me does it. These particular drugs, in terms of dosing, again, we always go slow. We start low and go slow. That's the way we do it. So if it takes your healthcare provider a little while to get your blood sugar under control with these medicines, that's normal. So because we usually like to be very conservative, start very slow, and then we titrate or move the dose up as we need to. The main thing to know about these medications is that they can sometimes increase your risk of a urinary tract infection. And it's because of the way that blood sugar is dumped into your urine. And you may, in fact, some of you may have done urine blood sugar testing in the past to see if your blood sugar was high. We don't commonly do that as much anymore, but we used to do that a lot. And that's something that you may notice. But because of that increased blood sugar, or that increased sugar in the urine, it can increase our risk for having a urinary tract infection. And that's both in men and in women. So very important to know that as well. And then we have some injectable medicines that are not insulin. So we've covered insulin therapies, short-acting insulins, long-acting insulins. We've covered oral therapies. We covered metformin as one class. We covered sulfonylureas as one class, which are the glipizide and glyburide and amaryl. Then we covered the DPP-4s, okay? We covered those. And then we covered those sodium sugar transport drugs. And now we're covering some injectable drugs that are not insulin. And these medicines, there are actually 1, 2, 3, 4, 5 of them. And you'll know these drugs because it says a Tide. Now these are not University of Alabama drugs. Tide rolls, but that's how you can remember it, you know. So exenatide, liraglutide, and Roll Tide. All of them right here, okay? Everybody said, I want one of those Roll Tide. Now, some of you say, why is there not a War Eagle drug? I don't know. We don't have one of those yet. So anyway, here are all these drugs. Byetta is the oldest one of these that's been on the market for the longest. So that may be the one you're most familiar with. But Victoza has been around a while. Tanzium, Trulicity, and Adlixin. And these drugs are injectable medicines. They have many of the same adverse side effects that go along with all the other medicines we've talked about. We have to monitor our blood levels to make sure that our kidneys, our liver, and our pancreas are working like they're supposed to. We also are going to note with these that there is a little more likelihood of having a low blood sugar reaction, and that happens pretty commonly. It is seen in some patients that use these medications, weight loss occurs with these medicines. And so it should never be prescribed for weight loss to help someone lose weight, but it is a side effect that some people notice that they might lose 5 or 10% of their body weight, which is ambitious. Most people lose a couple of pounds, so don't get overly excited about that, but it can happen. So those are these medicines, and these medicines would never be used by themselves. Not really. We would not use these drugs alone generally in treatment of diabetes. So if we were trying to treat someone's diabetes with insulin therapy, I'm going to use insulin therapy. If we're going to use the oral medicines, I'm going to start somewhere else. I'm not starting here. I'm starting with metformin or glyburide, or with one of those DPP-4 inhibitors that we talked about earlier. And I'm not going to go over the dosing. Just know that you do have to pay attention when your healthcare provider tells you when to use the medicine and how far in front of a meal. Pay close attention to that and do it exactly like they say, because your risk of low blood sugar reaction can really go up. So let me talk about insulin pumps. Insulin pumps are becoming more and more common. Insurance companies are paying for insulin pumps now pretty routinely. Should you go to an insulin pump or not? Well, an insulin pump is really designed to give you more flexibility and freedom. That's the whole reason why an insulin pump exists. It's to be able to give you the flexibility and freedom to do whatever you want to do and go about your business without having to worry about stopping and finding a needle and pin in or drawing up your insulin syringe. It makes life a little bit simpler for you. Insulin pumps are not cheap and they require commitment. So before you go to an insulin pump, first of all, you need to be on a fairly consistent dose of insulin and have demonstrated that you know how to do these short-term and short-time insulin dosings. And usually most healthcare providers want to see that you've done that successfully for about 6 months before they'll consider an insulin pump. They want to make sure that you're really using the insulin correctly and that your blood sugar's in a kind of a stable place. If your blood sugar's jumping all over the place and you've not gotten good control of it, I probably wouldn't move to an insulin pump just yet. But if you've got good control of your blood sugar and you want flexibility and freedom to not have to be tied to an insulin pen or to have to draw up doses, insulin pumps are great. Insulin pumps especially are good for athletes. We see a lot of people who are athletic or do a lot of jogging or running or swimming and so forth, and they want that flexibility, and because exercise can change our needs, insulin pumps are becoming very, very popular. So absolutely, they're good. Now, I am going to end it with that.